So I'm at East Tennessee State University now, but I did spend 9 years in Nebraska with Dr. Schaefer, and so have experience across a couple of different rural settings and have piloted telehealth programs in both of those settings. A couple of, I don't know if these are disclaimers or caveats to my talk. One is that I'm a psychologist, and I talk about telemental health here on this slide broadly, but really I'm going to be talking about psychosocial interventions for children, not so much the telepsychiatry piece, which is really a different kind of animal from what I do. I'm also a pediatric psychologist, and so my comments today and examples will be mostly about kids, but these data are true for all of psychosocial interventions and psychology as a field, and I'll try to kind of draw that point out as we continue to go. So, and there are no embarrassing slides of tractors pulling my car through the sandhills. So this is one of those shameless promotions of the cuteness of your children slides. I wanted to tell a story about a 3-year-old to start my talk, and it just so happened I had a handy picture of my son when he was 3, so I decided to use that. I couldn't use the patient photo, of course. The story I want to tell is about Douglas, which isn't his real name. He was referred to me by a pediatrician about an hour and a half away from where I live, which is in a really rural part of East Tennessee, near the Virginia and North Carolina borders. The pediatrician was concerned about Douglas. He was in his 3rd foster placement at the age of 3. This turnover had all happened in the last 18 months. And the turnover was happening because of really bad tantrums, physical aggression, biting, tearing things apart, self-injurious behavior, stuff that's real scary to parents who volunteer their time and energy to take care of kids and not really are not really trained to deal with these kinds of behaviors. The foster parents who had Douglas at the time that this pediatrician spoke with me was very motivated to keep Douglas and not wanting to be another liability in a string of referrals. And so she, she really wanted help. He had been in treatment for over a year with a local therapist and not improved. And so the idea was that they were going to drive an hour and a half to Johnson City to be seen by me and then return an hour and a half, so 3 hours round trip to get regular treatment. I'm always glad when these kids make their way to me or to somebody who can provide treatment, because children who are 3 who have really bad behavior problems like this don't tend to get better. The prognosis is poor. As they get older, those problems tend to sort of come up in multiple domains of functioning, difficulties in school, difficulties with peers, difficulties with adults. They can't really get along in lots of environments. And then it turns out that when you look at how that goes across the lifespan, it tends to go poorly. And when you look at these reviews by Olweus and Zumkley, these are reviews and meta-analyses of large numbers of studies, prospective, longitudinal studies that show that behavior problems in children are as stable as intelligence is over the lifespan of individuals. And so we really have to help kids that are having these kinds of problems, and to the extent that we don't, there's just a huge liability to society and to children across their whole lives. The good news is, and this is one of the things I love about my job, is that our field has developed this great evidence base for addressing these concerns, a really great evidence base. And so when Douglas shows up and I'm in my office, I know really exactly what to do, and it's very protocol driven and very straightforward. We have over 50 years of research on parent behavior management strategies. Some of that research is on specific programs to help kids like Douglas. Others are on elements within the programs, like the use of timeout, for example, or the use of differential attention with children. And there are hundreds of studies, and this an example of a meta-analysis there, Fabiano et al., 2008, looking at dozens and dozens of studies showing moderate to strong effect sizes for these types of interventions. And so, I know I can fix this kid if he comes. And this little picture on the side is a therapist doing one example of an evidence-based treatment, parent-child interaction therapy. There's lots of very good treatments out there. It's really a point of pride within my field. Just so I had to put the slide up there. This study was the AHRQ sort of put this study together, and it was just published in Pediatrics the other day, where they reviewed 55 studies of this type of research in parent training and compared it with 15 studies of medication treatments for children with acting out behaviors. And you can see that the results showed, and some of this is meta-analysis and some of it's just a qualitative review of the literature. The summary was very strong evidence for parent training and weaker evidence for using medications for preschool children with disruptive behavior. So like, yay, I can do this. And I want to just at this point say this is true in my field in pediatrics, and ADHD and conduct problems and oppositional defiant disorder are the most common referrals that I see. So this is great that we have this. But we have these kinds of interventions, and they do outperform medications across a variety of areas. Anxiety disorders in children is one, but also true for anxiety disorders in adults. And there's also a very nice armamentarium of evidence-based treatments for adult problems as well. I just don't have time or expertise in all of those. But the field has come a long way in terms of kind of developing these treatments and knowing that they work. The problem, however, is that we haven't really had any public health impact in terms of improving people's lives. And so a recent study in the United Kingdom looked at parent ratings of conduct problems in adolescent boys from 1970s, 1980s, and then again the early 2000s, and showed that in fact it seems like the perception is that conduct problems in adolescent boys, not just in the UK as was done in this study, but across the Western countries, is increasing. And you don't have to be an academic and look at all these reviews and studies and stuff to know that. You can look in your newspaper or Time magazine and all of the concerns about bullying, television violence, guns in schools, etc. And again, I'm a pediatric person, but it turns out to be true that mental health problems are increasing really across all populations, not just kids. And so this recent study by Twang in 2010 showed, pretty much a 1 standard deviation increase in problem scores across the last 70 years. So, on the one hand, it's like we have this great armamentarium of treatments. When I was coming up in graduate school, that's what it was all about, was learning these evidence-based treatments, and we're going to go out and save the world. But it turns out, 15, 20 years later, really haven't done that. So, of course, the question is why? And one reason, and I'll talk about this reason for just a little bit, is that there are these tangible barriers to getting this type of treatment to people. And that's a lot of what you've heard about this morning, is just kind of using technology to address these really straightforward things, like there aren't any mental health professionals out there, so how can we overcome that barrier? What about these logistical barriers like transportation and the fact that it costs you much? And in mental health, it adds a copay and it adds all these additional costs, and people don't have good coverage for mental health care, and that's a barrier. Mental health bears this additional barrier of stigma, and people don't want to be referred to see me. They don't want to see a psychologist or a shrink or whatever I happen to be called. And so that's another barrier. And then there's just a plain old lack of awareness. Maybe these last 2 bullet points are related. People don't know when they need help. They don't realize things are as bad as they are. They don't know how to diagnose or self-assess that it's time to get help. It's a little different than a medical problem where it's a little more clear cut that there's a problem. This is a little bit more like, is my problem worse than everybody else's problem? And then a lack of awareness about services as well, like where do I go to get help for these things? These all are particularly true in rural areas, which is where I've always practiced, but I think they're very true in lots of places. And so, of course, telehealth and telemental health is kind of an obvious solution to those problems. It's sort of how I viewed it when I first met it. And it's come a long way, and there have been some things happening even in the last 10 years or so that have put it in a place where it's really in the position to make a big difference. For telemental health, whether it be psychiatry or psychology, it's it's pretty easy to do. We don't need a lot of ancillary equipment. We just need two-way video conferencing. It's so easy to do. It was done as early as 1957 in the VA in Nebraska. And we've got lots and lots of demonstration projects now that you can meet somebody by telehealth and do two-way video conferencing, kind of psychosocial interventions. Nice thing is that now Medicare is reimbursing those types of services, psychiatric diagnostic evaluations, medication management, and also psychosocial treatments and therapy at the same rate as face-to-face services. So that builds the platform a little bit more. There's volumes and volumes of studies now showing that people like it, patients like it. There's all kinds of satisfaction surveys given across lots of demonstration projects. Ours was one. When I was in Nebraska, we saw about 50 patients in that program when we were piloting it before I left. And we did satisfaction surveys, collected data on about half the sample. I'm just putting this up here because it's kind of representative of what the literature shows overall. That people on a scale from 1 to 6, where 1 means they really hate it and 6 means they loved it, really loved it. They felt like their problem was heard and understood, and they were comfortable. They disagreed that the camera made them embarrassed, and they felt like it was as good as a face-to-face encounter. Some of these questions about, would have had to travel, it would have cut into work time, would have affected my wages, would have been inconvenienced. They're agreeing with those things. Like sort of some evidence there that this really is kind of taking down some of these tangible barriers that we identified as one of the reasons why the services weren't getting to people. And I like that last item, would prefer a face-to-face visit rather than telemedicine, and that one just comes right in the middle. People aren't strongly agreeing or disagreeing with that statement. And what's nice in the last few years, 5, 6, 7 years, is we're starting to see a growing evidence base that providing psychosocial interventions, behavioral interventions by two-way video conferencing works just as well as providing those services face-to-face. So we've got a variety of study designs, descriptive studies, pre-post studies, and even a handful of controlled trials now using telepsychiatry, but also, like I said, psychology and psychosocial interventions and assessments across a whole bunch of settings, kids in communities, kids that are incarcerated, kids in schools, and across a lot of different kinds of presenting problems. Kids with acting out behaviors, kids with depression, doing neuropsych evaluations, and all of these studies are coming up clean. They're all showing that you get commensurate results when you do behavioral health through the video as you do when you do it face-to-face. And that's a big deal for our field, because lots of people feel like the relationship is a big part of what helps motivate people to make change. And so the question of having that relationship through a screen is one that comes up. And I didn't want to spend lots of time reviewing all those studies, but this is where I got some of the most recent data without having to dig too much. This book was just published, Kathleen Myers and Carolyn Turvey's book, and it underscores the point I'm trying to make on the side, which is that it's got a chapter on geriatrics, and it's got a chapter on the Veterans Administration, and a chapter on this and a chapter on that, and shows the evidence that's accumulating across populations. For telepsychiatry, more so. The book is a little bit leaning in that direction, but it does have some of the growing evidence around psychosocial interventions and how those have gotten more and more support. But I don't think that, so the first problem was the barriers, and I think telehealth has really helped address some of those. But I think there's another reason why behavioral health interventions are not being kind of really widely disseminated and picked up by the public and making a huge public health impact. And that reason is mostly a product mismatch. That what was developed by our field over the last 50 years isn't exactly synchronous with what people are looking for. And so it seems like maybe what we were doing for the last however many years is thinking very linearly about our plan. that we were just going to develop these interventions. And the main way to evaluate whether they were good or not was whether we found evidence for them. So we have evidence, we have bad interventions for which there are no evidence, and then we have these great interventions for which there's strong evidence. But we really weren't thinking about the fact that there's a whole other dimension that goes into play, and that's like how in demand is the service, not just whether it works or not. And so, you know, what we'd like to believe is that the things that we developed really great interventions for that work are also the ones that everyone wants. And the things that we have nothing, no evidence for, the things that no one wants. But of course, that isn't how it really works. The way it really works is that there are treatments for which we have strong evidence, then people don't really want it, don't really like it. And then there are things for which we have no evidence that people kind of wish we did have. I'm going to talk just a few minutes about what I mean by this. You know, do patients want what we have to offer? I would argue that in a lot of cases, the field has not really thought carefully about some of the issues that come up for patients. For example, setting and accessibility of services. Mental health services are typically administered in specialty mental health settings, and it turns out that very few people access specialty mental health. So a recent statistic is that about 25% of the US population will experience a significant psychological problem this year, 25% of the population. About 20% of those people will actually find their way to specialty mental health. It's a very small number of people. In the meanwhile, we know that out of the whole population, about 60 or 70% of people go to their primary care doctor when they have a concern about their life, about stress, about depression, about their kids' behavior. So people are traveling through primary care clinics more so to get access to these services than they are to specialty mental health. And there are lots of examples, schools and other community-based settings where people are looking for those services and they're not there. Another issue is length and timing. So a lot of specialty mental health services and these treatments that I'm describing were developed based on 8 or 9 or 10 or 12 or 13 or 14 one-hour sessions. And it turns out that people don't really want to sign up for all that. When people are very distressed and they're undergoing a lot of misery and concern about something that's going on for them, they want help and problem solving in that moment that they're experiencing that. And so when you look at the literature, for example, the literature on child behavior management that I was citing earlier that's so well documented, most of those studies were done in pretty controlled university clinic type settings where we had a good group of parents that came to, on average, 9 visits, 9 one-hour sessions, and we showed with all of our data that we made them better. But when you look at community samples, like real-world samples of people, like how many parent training sessions do you think most parents attend? The modal number is 3. And that's actually a lot better than psychotherapy in general. Does anybody know what the modal number of psychotherapy visits people attend is? It's 1. They come to 1 session. And there's evidence that people get better in 1 session, and that we don't really have to provide, and it doesn't even have to be an hour long, as it turns out. There's a lot of myth in the field about this, 1-hour session. It turns out that we can provide a lot of great treatments in shorter periods of time, in 1 or 2 15-minute sessions that can be just as effective, maybe even more effective than some of these more cumbersome interventions we've been developing all along. And then lastly, treatment experience. We've done a lot of qualitative studies, asked lots of people, like, what do you want when you get treatment? What would have made your treatment better? People want coordinated care. They want their team to kind of interact. And that's just one example of what they're looking for in the treatment experience. We haven't been providing that. Specialty mental health has been in a silo and separated out from other care. And so when you look at who accesses specialty mental health services, I've seen the statistic that it's about 3 to 5% of the entire population, which is a really, really small number, especially given the numbers of concerns people have. We know case rates of depression and anxiety and all these kinds of basic mental health problems are much larger than that. In addition to the fact that, I've been talking about the mental health field and all the kind of evidence-based treatments we also have a fair armamentarium of treatments for behavior change. I have an evidence-based pill swallowing protocol that I use in primary care all the time to teach kids to swallow pills when they don't want to swallow pills. Very basic kinds of behavior change strategies that we can do that help increase the performance of medicine in real-world settings. So kind of what this points to, I think, is that for behavioral health, the problem isn't just about kind of overcoming these tangible barriers and bringing this product that we have to people in its existing format. The problem is really about kind of being adaptive about our formats and changing our formats and looking at novel ways to bring the services that we know work to people. And I think that our field is starting to make some really good gains in that area. So the solution, obviously, that I've really liked kind of boils down to this equation is that if you want to have some impact, you need to have effectiveness, surely, but you also need to have really significant reach. And a lot of the work that we've been doing at East Tennessee State University has been more about reach than effectiveness per se. So right now, I want to focus on this first solution, which is the idea of staying sensitive to stakeholder demands and adapting, kind of like I've been saying, kind of trying to find new ways to get these treatments out there to people and make them a little different or maybe more palatable. And when I say stakeholders here, I don't just mean the patients themselves, but also a lot of you, nurse practitioners and educators that are working within telehealth networks and primary care providers who are in kind of the field and really have the leverage to kind of bring people into us and get people access to these treatments that work so well. So what we have done is tried to do this, tried to stay sensitive to these things and adapt our program. This map shows where I live and where East Tennessee State University is, where the yellow star is in the little corner of the state over there. We have a doctoral program in clinical psychology, and our focus is on rural primary care psychology, so we're training all of our students to work in rural primary care clinics. This telehealth project fits right in with that mission. We started the program in 2009 and really spent about a year and a half kind of not quite a year and a half, about 9 months kind of scaling the plan and getting the equipment set up and getting a program put together. And since then have been seeing patients. So I think we have about 2.5 years of patient service under our belt at this point. And our direction is actually Terry Eagleton's in the office or in the room over there. He's the director of the Tennessee Primary Care Association. They're the ones that hold the HRSA grant that funds us as a contract under that grant. Those 6 or so red dots show locations where we are actively providing behavioral health services in primary care clinics. So we've linked our behavioral health services right into those kinds of settings. And there's one dot that I want you to note in particular. It's up on the far right corner. That's Mountain City, Tennessee. It's one of the lowest ranked counties in the state as far as health factors are concerned. And I feel weird being in this room where everyone's bragging on how low down they are. I thought Tennessee was bad, but apparently we're a few notches, not many, but 2 or 3. Anyway, Johnson County is pretty low in terms of that. I'm going to talk about that data a little bit more specifically in a minute. So that's our clinic. Our services are staffed by master's level clinical psychology graduate students. These are people who are almost to their doctorate, and I supervise them. This is me supervising Jamie Tedder. She's one of our clinicians. Trying to think, and so in the last 2.5 years, we've served, I think it's 191 distinct patients with maybe 297 different visits. And that's actually pediatric and adult visits. There's a span of services that we're offering. But I want to tell you a little bit about how we've done this adaptation thing that I mentioned. When we started the clinic in August of 2010, we went out to all these sites that I just showed you, not quite all of them, but almost all of them, and we talked about the service, and we talked about, behavioral health, and that we can do this mental health stuff with these people that are having kind of mental healthy problems, anxiety, depression, this sort of thing. But we also really have pretty good skills in behavioral health. So if you need somebody to quit smoking or lose weight, all these kinds of health psych types of issues. And the physicians were just like, this is great. We can't wait to refer someone. We've got someone in the exam room now. Where's the paperwork? What do we do? So we had a little packet of paperwork, and we had a phone number that you could call to get in touch with us for getting this set up and scheduling it. And we sort of had the sliding scale worked out because we're a graduate clinic, and we can't bill because these are graduate students, they're not licensed and all this stuff. So we had all this stuff worked out, and we had this really enthusiastic response from all these physicians and all these people, primary care providers out in the communities. And we went back to ETSU and turned our televisions on and got our hand on the phone, and you can see August, September, I think we had 1 or 2 people come in, and then October we had none. And so we quickly refocused our efforts. And we thought we were doing pretty good because we're in primary care, right? That's where these people are. Our equipment's right there. It should be good. But it wasn't so good. So that phase line shows you where kind of we started to problem solve a little bit and adapt our services. We're okay, we're grant funded, so let's do this. Let's make this more like what real integrated care looks like, where behavioral health services are offered in a way that keeps pace with what primary care does. We're going to be kind of more population-based service. And so in integrated care, when a behavioral health provider works in primary care, there's this cool thing where the primary care provider's meeting with a patient, and they're talking about how their throat hurts, and we take care of that, and then just as they're about to leave, they go, and I can't sleep at night. And the provider is able to bring the behavioral health person in and do this warm handoff. Let me introduce you to this behavioral health consultant. She knows all about sleep and how hard it is to sleep and how to help you get better sleep at night. And then we would kind of be in there. Warm handoff is the idea. We changed the model so that it included something called open access hours. And we hoped that this would facilitate warm handoffs. Open access meant that our clinicians were available all day. Patients did not need appointments. They did not need to fill out paperwork. And there was no charge for that first kind of consultative visit, which usually lasts 10 to 20 minutes in length. We're just trying to see if we can get you some quick recommendations and get you on the road. If we can't provide something to you in this brief period of time, then we can go into this more specialty-focused model. And you can see that had a pretty big effect on our referrals from that point forward. Now, I'm not going to show you all the data from all the years of our clinics. We've had variability. We've had clinics that had made lots of referrals and then stopped. We had clinics that were big referrers, and then for whatever reason, their telehealth equipment got moved to a closet somewhere and no one knew where it was. I mean, just all kinds of strange things happen, and you're not on site, so you kind of don't know what goes on sometimes. But we've seen variability, we've seen a lot of shift. One thing that we are concerned about is really maximizing what we can do and really penetrating population bases within each primary care. We don't want to just see the people who are really struggling with severe mental illness. We want to see people who are having problems with kind of one-ticket items, sleep, or just managing pain, or all these kinds of sort of short orders, as well as prevention. So kind of really trying to build up our service, and that's what we've really been focusing on. So here's another effort we made just to show you some more data to think about. This is data from just that one little red dot that I showed you up in Johnson County, Mountain City. So when you see the bottom there, those are referrals they made per month from October to August. And you can see it's sort of variable. Our students get a couple weeks off for the semester break in December, and so things get a little slow, but you can see that mostly we're averaging something between 8 and 12 patients a month from this one clinic, which is staffed by 2 nurse practitioners on a daily basis, so it's a pretty small operation. We wanted to see if we could get more referrals. We could beef up the referrals, increase our kind of traction in that clinic. And so what we did at the beginning of September was we started an in-person service. So we actually went up there and we still do, we spend a whole day in Mountain City every week and do integrated care the on-site way. It's about an hour's drive from Johnson City, so this is pretty feasible. And we thought this might help the providers get more comfortable with using telehealth, making referrals to telehealth. They know the provider that's on the other end now because you're seeing him one day a week. And so maybe making that personal connection might make a little bit of a difference. Because again, the stakeholders here are not just the patients, the stakeholders are also the providers and the educators on the other end kind of getting patients to us. And we felt like they didn't know us well enough. They didn't know what we did. They didn't know the extent of our services. I've worked in integrated care for a long time, and I've been in practices for 2 or 3 years before I felt like the physicians really understood the gamut of behaviors that I can address. And so how do you do that when you're sitting inside of a television all day? You're not interacting with the physicians at all. So we felt like this one day of on-site services would really help. As you can see, we don't have great data for that. It hasn't, if anything, I think besides the months of November and December, it's kind of stabilized our data around 10 patients a month. But we're really looking forward to seeing how that kind of goes forward in the future. The interesting point is March, where you see that there's like all of a sudden this big jump, and this just happened last month. As it turned out, there was one day when our student couldn't drive up to Mountain City. It was not a weather-related issue. He couldn't go up there. We were launching another project, and we needed him to be on site that day in Johnson City. And he saw all 9 of his patients that he was supposed to see in Mountain City by video. They came in because they were scheduled to come in, and they just got walked into the video room. So that just changed our numbers dramatically. Now, one would think, like, well, that's great. You know, if there's ever a snowstorm or something, you could do this. But there was a snowstorm last week, and he drove all the way up there. He has, you know, the whole all-wheel drive, right? So the mountain roads. And he got up there, and he had no shows for the whole day. Like, the people that live up there don't come in. So, so there's some interesting kind of ways to think about these data. So in addition to adapting and really thinking about what do our stakeholders need, I think the second solution that we're really focusing on is thinking about technological ecosystems. Like, where are people? What technology do they use? We've developed a lot of questionnaires for rural areas around us and just kind of surveying people. Like, do you all go on Facebook? Do you use smartphones very much? You know, in Johnson County that I was mentioning earlier, there are places where they're just starting to get broadband. So it's not a straightforward deal. This kind of whole idea of the digital divide, and some people, you know, just still don't have access to the stuff that we're used to seeing on a daily basis in more urban areas. So we're kind of trying to learn more about that. We've done some focus groups up in Johnson County, and it appears that Facebook is really popular among younger parents. So we're trying this right now. We're using this Facebook page. We called it Johnson County Parents for Kids instead of, does your kid need telemental health services? That was the other idea that we had. We decided not to use that one. But what we're doing is, it's kind of a double platform. It's partly a Facebook page that puts blogs and articles of interest around kids' behavioral health on it, as well as like kind of cool things for kids to do in Johnson County, which happen about once a year, as I'm learning. But we also put plugs in there about things that are happening with the telehealth clinic. And they're kind of obtuse. So it's like, do you have questions about how stressful it is to be a parent? Today, 3 moms came and talked to our clinician at Roan Creek Elementary School. And there's a little picture of the equipment and a smiling clinician. So kind of helping parents know that the service is there. But I hate it, but it sort of is kind of like disguising the services in a way. This whole concept is a little bit about marketing, but it's also a little bit about changing the way the services are delivered. I have this bullet point up here as well about text messaging versus plain old telephone systems. And I just wanted that as a prompt to me. There's lots of different technological ecosystems. Obviously, we have lots of behavioral health apps now, and there's all kinds of different ways, internet portals to get behavioral health services. It's interesting that like some populations use text some like ethnic groups use text messaging more than others, or studies where they use text in pots found that older folks preferred plain old telephone calls, and even if they were like pre-recorded messages over getting text messages. So kind of knowing what your population is about and how they engage in technology, so you can find those ecosystems and put treatments, really, as well as plugs for treatments out there. And then finally, this is sort of the wave of the future, this idea that behavioral health interventions should really be offered as a portfolio of options, not just by traditional face-to-face sessions, and not even just by traditional face-to-face sessions that are now through a video machine, but also that we figure out ways to offer it through asynchronous methods, by smartphones, by these group medical visits that Dr. Lowry was mentioning earlier. We've had lots of success with those, and behavioral health has a lot to add to group visits, particularly with chronic illnesses, where we can talk a lot about making lifestyle changes and how to go about that. Offering services through social media, using paraprofessionals, bibliotherapy, blah, blah, blah. There's all these different ways. And when we offer it in these many different kinds of ways, we're more likely to put the services in an existing path that a patient is stepping in, rather than putting it somewhere where the patient has to go out of their way. And some paths will be more facilitating of some patients getting services, and other paths will be better for other patients. I just made up this pie chart. It's not real. Like, I just made this up. I don't know how many people want bibliotherapy or whatever. So this is not an accurate pie chart, but I do have the world's most accurate pie chart. I love that. You know, as an empiricist, it just feels good. Okay. So I end on the story of Douglas, who I talked about a little bit at the beginning, and as it turned out, they drove an hour and a half to see me for 4 visits. I don't know, that's like 12 hours of driving or something. And he got better, and he did really well, and the parents ended up adopting him. It's like a really happy story. And it makes me feel great that I was able to provide those services. It would have been nice to have those services available by two-way video conferencing and save that mom 12 hours. I think about that sometimes. But what I think about even more are all the Douglases that are out there whose parents don't have the resources or the willingness to even accept those kinds of services by two-way video conferencing, that are on a different footpath. And how do I get to them? And how do I get these ideas to them? Because a lot of these concepts that we taught Douglas's parents are really kind of easy to boil down into something that could be online, or it could be on a smartphone, or it could be delivered by a lay person in the community, a church leader or a teacher or somebody like that. So I think, I think about those kids, and it concerns me that, the reach of our services is so narrow.